So I'm not going to talk very much at all, but I am going to introduce these two gentlemen here. I also am going to use the word otolaryngology as much as possible because I practiced it many times. I've been told that I can say head and neck surgery, but I'm going to go with otolaryngology because it sounds cooler. Right here we have Dr. Uma Duvuri, and he's the assistant professor of otolaryngology at the University of Pittsburgh Medical Center. And then we have Dr. Eric Gendon, the chairman of the Department of Otolaryngology and chief of the Division of Head and Neck Oncology at Mount Sinai Hospital. And they have some presentations. They both have a presentation. They're each about 20 minutes. They're going to tell us what we have now in terms of robotic surgery, as well as where we're going in the future. And then after that, we're going to open it up to questions. I have some questions. I have a feeling you all will have questions, hopefully. And again, if you do have a question, I'll ask you to sort of raise your hand, and I will point at you, and you can go over to that microphone over there. If you have a burning question and you want to just go over to the mic and get in line, that's also fine. But you just need to use that microphone because we are filming, and so people need to be able to hear your questions so they can hear the answers. And with that, I'm going to turn it over to Dr. Gendon, and we will have a presentation. Is that right?
Great. Well, thank you very much for the opportunity to come and speak with you today about what we think is very, very exciting in technology and innovation, but also in medicine. And it impacts every single one of us in the room, and some it impacts even more than I think will have expected. But after the end of this presentation, you'll understand why that is. Future of robotic surgery is an interesting topic, and robotics in general is an interesting topic when it comes to medicine. You know, robotics was adopted by industry back in 1954 when the first programmable robot came out, and it was only 8 years later that GM adopted that into their assembly line. And yet, here we are 60 years later or so, and only now is medicine starting to adopt what robotics can bring to taking care of patients and treating patients. But it's a sticky and a difficult issue because most of robotics, as you will know and understand through the talk, are very expensive. The innovation, the technology is very expensive, and yet we're in a time where we're limited in terms of our finances and the constraints in medicine. And so what robotics has done in industry has not taken hold in medicine until recently, largely because the public perception of robots and robotics. If you were born or you were a kid in the 50s, this is probably what you saw in terms of robotics. They were a little scary. Nobody knew what they were all about. They were typically from Mars or some other place. But yet in the 70s, robots became intelligent, and they became friendly, and they became a part of answering questions and doing things in a way that was better than what the human could do. And even now, robotics is being marketed to our children in a very friendly way. And so the third, fourth, fifth, sixth decades of our life now, these are the group that adopt technology because they've been raised in an era where technology is good. But yet some of the older folks may not or be a little less trustworthy when it comes to technology. This was the first robot that was introduced in 1985, and this was actually introduced for exactly the reason I was talking about, to try to perform brain biopsies in a more precise way. The concept that a robot could do something better than a human. And in fact, this robot was used for brain biopsies. It's the Puma 650. It was also used for prostate surgery, and it quickly fell out of favor. What happened is NASA, with the Ames Research Center, started to adopt this idea of robotics, and they started to see that robotics could play a role in medicine and space. And then SRI, the Stanford Research Institute, got involved in the 90s, and they started to create robots that could do just about anything. And the U.S. Army then took these ideas and began to fashion them in a way that maybe they'd be able to use robots to pick up injured soldiers in the field. And maybe we could get robots to perform surgical procedures where the surgeons were miles and miles away out of harm's way, yet the robot and the soldier were in the field. And as much money, and a tremendous amount of money was spent on this, it really didn't come to fruition, but it did engender the fascination of private companies, one of which was Intuitive Surgical, but there are many, many others. And what they did was They designed and redesigned this manipulator that allowed the robot and the robotic arms to move in a way very similar to the human hand. I mean, the human hand is an incredibly precise and complex feat. And to be able to get a robotic arm to move in all 360 degrees and twist, remove the tremor, was truly remarkable. And it took this telemanipulator to be able to actually do that. Prior to this, they'd been using joysticks. And when you add to it the three-dimensional camera, now you had a combination that could change everything. And if you have had a chance to look at the robot and sit down at the console and look through at the three-dimensional camera, you'll understand what I'm talking about. There's almost no one who hasn't sat down at this and looked through it and said, wow, this is really neat. Because it allows surgeons like myself to get into areas of the body where we could never heretofore get to, and not just see, but see three-dimensionally in an incredible way. And so taking this instrumentation and putting it all together, this is what this looks like. And what you have is a console. That console, it can be within a foot or 2 feet from the robotic instrumentation in the operating room table, or it can be 10,000 miles away. And through that console, seeing three-dimensionally, you can move not one, not two, not three, but 4 different arms with suctions and lasers and all kinds of suturing instrumentation. And so what you can do with a robot and robots like this is truly, truly amazing. And so the question comes up, how do we adopt this? How do we use this? And can we use it responsibly? Now, I'm going to talk about and diverge just a little bit here for a second and tell you about an epidemic that has occurred. Now, for the last 150 years, throat cancers have developed in men and women as a result of heavy smoking. And those cancers are very, very dangerous. Only 50% of people who develop these cancers survive, in spite of radiation, surgery, chemotherapy, and all 3 put together. But over the past decade, we have seen an epidemic of viral-induced cancers. HPV, human papillomavirus, that's the virus that causes cervical cancer in women, the only known cause of cervical cancer. That's been transmitted to men now over the past 2 decades. And men, at alarming rates, are developing throat cancer. And these are young men. These are men in their 30s, 40s, and 50s, and that's why it impacts most of us that are in this room today. And the issue here is these tumors are often no larger really than the size of a walnut, and the question becomes, how do you manage them? If you look at this graph on the left, the little yellow line on the bottom going down is cervical cancer. It's waning. But if you look at that steep curve, the blue one, that's the rate of throat cancers in young men. It's unbelievable. And if you take a look at this graph, that cross, what that shows you is that in the next 4 or 5 years, throat cancer in young men will be more prevalent than cervical cancer in women. It's quite amazing. And yet the question comes up, how do we treat these patients? Now, when we talk about treatment of head and neck cancer, you have a couple of options. For years, we treated patients with high-dose radiotherapy and chemotherapy. The problem with that is that the side effects of treatment destroy patients' lives. They can't eat, they can't drink. 20% end up with tubes in their stomach, tracheostomies. It's really horrific. And the smokers and the drinkers that we treated were in their 7th or 8th decade. Now we're dealing with 30 and 40-year-olds. Can we do this to a 30 and 40-year-old? And that prompted looking into other approaches. Now, the open approach to surgery, which was traditionally used, and that's how I was trained up until recently, was this incision through the lip and the jaw. Raising up the anatomy, getting access. It's a 15-hour surgery to cut through the lip, to cut through the jaw, all to get back to the throat. 15 hours in the hospital for 2 weeks, tracheostomy, tubes, to take out a tumor the size of a walnut. And when you take a look at the operating room where we do these procedures, the use of materials and the cost that goes into an operating room like this are astronomical for a tumor the size of a walnut. In comes robotics. Now we suddenly ask ourselves the question, what if we took the robotic instrumentation and placed it into the mouth with a 3-dimensional camera and removed these tumors robotically? What would happen then, and what would it do to the costs? And the costs we're going to talk about at the end of the discussion because they're critically important to determining what's a sustainable innovation, not just what's innovative. And so if you play this first video for me on the lower left, if you've never seen robotic surgery, let me just show you what this looks like. You're looking at a robotic instrumentation. There's the patient on the table. That's a professional hockey player. He's only 31 years old. There I am in the back in the console, and I'm using the instrumentation with a touch point laser to remove the cancer. This procedure to take out this cancer requires no external lip-splitting incisions, no cut through the jaw, and instead of 14 hours, it'll take about 2 hours to do. If you go ahead and click the second pane up top, the video, what you're going to see is what we're seeing through the console. And this is the pharyngectomy using this touch point laser. And there's the cancer lifted up free, and I'm coming down along the throat, just adjacent to the carotid artery, all the critical structures that are in your neck, and you can see how little bleeding there is. Look at the lower panel right there. The lower panel, you're not going to see 12 nurses and surgeons standing around. I have one nurse standing by my side to hand me instrumentations. So we go from a group of 9, 10, 11 in the operating room to 1 or 2 nurses. You see the other people, they're standing there watching, and they're probably just observers. And what you see at the end in the top right is the reconstructed pharynx. This patient will not go home in 14 days. The patient will go home the next day, and the patient will go home eating and drinking. It hurts. It's a tonsillectomy, a big one, but they're eating and they're drinking. Quite a change. Let's go on to the next slide. But this is what we contend with. The robotic instrumentation, irrespective of which robot you're using, they roughly cost about $2.5 million, and it takes about $100,000 to $200,000 a year for maintenance. That's a lot of money. Now, robotics, when we look at the cost and the healthcare spending as a percentage of GDP, you see that big blue line. That's, of course, the United States. You've probably seen that a few times. And the fact is that we have to justify the utility of using this type of instrumentation and technology in healthcare today, especially because we're constrained. I would argue that a 2-hour procedure with a 1-day or 2-day length of stay is a heck of a lot better than 14 days in the hospital, 14 hours in surgery, and all of the materials that you're using to get a patient through care. And as we look at these technologies moving forward, it's incumbent upon us to do very technical, very important cost-utility studies to answer the question, should we be doing this? Robotic surgery, for example, was adopted initially by the urologists. 75% of all prostate surgeries are done robotically. But guess what? There's not a single published paper that demonstrates that robotic prostatectomy is any better than laparoscopic. That kind of trend, the way that we become enamored with technology can be a very dangerous thing. And so as we move forward, we have to ask ourselves the hard questions about quality and outcome and what's the cost and what are we getting, what are we doing for our patients, and is this an innovation that's going to really truly help not only patients, but our healthcare system, which is in dire straits. And so I'm glad that I had the opportunity to kind of share these thoughts with you. We'll talk a little bit more when we get to the question session. But I've asked Uma to come from Pittsburgh. He's really on the cutting edge of new developments in robotics and technology to talk about his thoughts on this.
Thank you, Dr. John. It was a hard act to follow. But I was asked to give a little bit of a talk or my thoughts on where I think robotic surgery is going and what we're doing today. You've heard very eloquently about, but where are we going tomorrow? What are we going to be doing with this technology in the future? And so I think of this a lot like a hammer and a nail. And so you've got lots of nails and you've got potentially lots of hammers. But really our task is to find the right hammer for the right nail and to do it the right way and to do it so that it helps people. So what I wanted to talk about in the next probably 10 or 15 minutes, and I'll try to keep this brief and open it up to the audience for questions, is a little bit more about what robotic surgery is today. You've heard about robotic surgery for the head and neck, but head and neck cancers are a small part of the cancers that actually affect people, the diseases that affect people. And so we're using robotics in a lot of different ways. We're using it in heart operations. We're using it for prostates. We're using it for gynecologic operations. So I'll talk a little bit about that. And then I wanted to give you guys an idea of where robotic surgery is going tomorrow. That is the next maybe 24 to 48 to 72 months. And then finally talk about the real future, the distant future, the more Star Trek type of stuff. And I collaborate on this because my background in bioengineering, I work with a lot of robotic scientists and roboticists, and I wanted to share with you a little bit of what I think is the most exciting part of what I do. So here are some thoughts that I put down. Questions for a futurist is what I called it. So where can we use a robotic system that we don't use it right now for the future? Will it be helpful? And as Dr. Jendon pointed out, how do we study it? And how do we know that it's really helping people and that we're not just doing something because it's cool, because you can do it? Because we could do a lot of things because they're cool, but it doesn't really mean that it helps everybody or helps anybody. So just to take a step back, surgery itself is an evolving art. And as we get new technology, we will use it to push the boundaries. And we all know that patients prefer smaller incisions and they prefer quicker recoveries. So while the robotic system was initially designed to help soldiers on the battlefield, as you heard about, it became pretty apparent that that wasn't going to happen very quickly. So what the Intuitive Surgical system and what the Intuitive Surgical company did was they really targeted this robotic system to surgeons as a technology that would reduce tremor. Wouldn't it be cool if you could operate and not have tremor at all? And the area that we think about tremor and surgical dexterity being so critically important is actually cardiac surgery, is heart surgery. So the Intuitive Surgical company went to cardiac surgeons and they said, hey guys, look, we can give you this system and you can use these little robotic arms and you can sew little vessels on the heart together, 3 millimeter, 4 millimeter coronary arteries, and you won't have a tremor and you can really put them together really, really, really nicely. And so the cardiac surgeons used it a little bit, but then they really didn't like it that much for some reason. They went away from it. Well, at the same time, the urologists noted this, and the urologists started doing laparoscopic surgery on the prostate. They were taking out the prostate through small incisions in the abdomen. And so they said, well, instead of using small incisions and little rigid instruments, why don't we put this robotic system into the body? And they did. And it went off like gangbusters. It went off so well that within 5 years, about 60% of prostates were being done robotically. Within 10 years, 75 to 80% are being done robotically. So as the Intuitive company puts it, they shot for the heart and they hit the prostate. So we get technology and we think it's going to be useful for one application, but then we find out it's really good for something else. So the urologists started using it and they started doing prostate surgery with it. And then they moved into gynecologic surgery, which is still in the pelvis. And then we moved into other areas like the abdomen, to do abdominal surgery, like removing gallbladders, which is a very common operation. And then we moved into doing head and neck surgery with it. And that's, in fact, probably one of the more recent fields to have adopted this surgery. But we clearly have a great benefit from it, as you just heard. No incisions on the face, no incisions on the neck for tracheostomies, and no feeding tubes. That really has changed how we treat these patients. And patients like the smaller incisions, and they prefer the quicker recovery. But what is robotic surgery right now? One of the most common things I get from my patients when they walk into my office and I say I'm going to use a robotic system to help take care of them, they say, well, doc, I don't want a robot operating on me. I came to see you. Right? They have this mental image still of a machine performing surgery autonomously. But in fact, that's not what robotic surgery is. Robotic surgery, as it stands now, is surgery in which the surgeon performs an operation by manipulating the hands of a robot. It's really a master-slave system. So the surgeon moves an instrument, moves a joystick, and that joystick translates to moving an instrument. In fact, the word robot, just out of as a side note, as a sidebar, comes from the Czech word robota, which means forced labor, by the Czech playwright Karel Kapček, who wrote a play called RSSR, in which there were these machines that served the masters. And just like the Terminator movies, the machines eventually gained intelligence and they rebelled. And they attacked the masters. And so there's still this idea and this image of autonomy and the fact that robotics may eventually move that way, but it's not right now. So what do we do with robotic surgery today? Well, you've heard about the 4 arms that can be manipulated from this console, this 3-dimensional camera that we have, these instruments that allow us to really miniaturize our own hands as surgeons into something as small as 5 millimeters and get into the body and do surgery. I mean, this is really cool stuff. 10 years ago, this would have been completely, out there, Star Trek-y. And yet, it's where we are now. It's what we're doing routinely. And so what we do now with this instrument is we have better motion. It's no tremor. It's stabilized motion. There are these instruments, and one surgeon can use 4 hands. So we've doubled our hands inside the patient's body. And what we're now taking to the next step is what we call single-site surgery. And transoral robotic surgery, or what you just saw the video of, is an example of this. All the instruments enter the body cavity through one incision or one natural orifice, in this case, the mouth. But surgeons are now making a small incision around the belly button and able to get into the abdomen and remove the gallbladder. So no 4 holes, no 4 ports, one little incision. And these instruments currently exist, and they're going to keep getting better. So we're doing this now. And we can go forward. But it's not just about single-site surgery for the abdomen or for the chest or for the oral cavity. There are lots of other robotic systems that are out there. One of them is this system called the Magellan system, which is used to do catheterizations. Many of you probably have had friends or relatives who have had heart catheterizations, where a catheter is threaded up through the groin into the heart. Well, that requires manual dexterity of the operator, of the cardiologist or the surgeon who's doing it. And here, this company has come up with a system that can be guided by a surgeon sitting at some console and can really hone this catheter to the right point in space to make this safer, to make this more facile. Similarly, this idea of targeting to the right space is really useful in spine surgery, in orthopedic surgery for people that have back problems or suffer from back pain. Many of these patients require screws or plates to be put in just the right angle. And you can imagine in the spine, it's not a place you kind of want to gamble with, right? This prime real estate. If you're off by 2 millimeters, you could paralyze somebody. So good spine surgeons practice. We train for 15, 20, 25 years to get really good at doing what we do. And this technology from an Israeli company called Mazor seeks to cross-register images taken of a CAT scan and images taken in the operating room from fluoroscopy, just as plain X-ray, and they actually put it together so that the surgeon then can use a robotic system to deliver a screw right through a pinhole incision on the spine, in the body, without making a big incision on the back. So what this lets them do is get really, really good accuracy. And what the system has shown is that a first-time surgeon, a young surgeon, can have an accuracy that's almost as good as somebody who's been in practice for 15 years. Isn't that cool? We don't have to practice on people anymore. We practice off people. So we reduce errors. If we reduce errors, maybe we definitely reduce complications, and theoretically we reduce costs. So again, we don't know this data, but this is kind of where we're thinking and where we're going, I think, in the future. And this is what that sort of system looks like. There's a big instrument that's attached to the operating room table and fixed to the patient's body, and then images are taken. These are registered in the operating room on a computer system, and the surgeon just has to place a screw right through this existing cannula. And this gives someone 1 millimeter accuracy, which is way better than what we had before. So this is another machine that's being used now. So this is what we're doing right now, right here. Hospitals throughout America, from Main Street all the way up to the academic ivory towers. But where are we going in the future? Where are we going in the near future? And in my mind, I see this as expanding the breadth of what we do now and making it more user-friendly, making it better. So what that means is taking the old Palm Pilots that you guys might remember and making them into iPhones that my 1-year-old daughter can use, okay? That's really cool. So how systems are designed and how they're implemented is just as important as how good they are and how well they're engineered. And that's all part of it. So what I'm showing here is some of the ideas that I think are going to be important in the future. Integrated surgical planning, integrated imaging, integrated feedback and haptics. So one thing that was not mentioned to date is that the Da Vinci surgical system, for all its benefit, because it's a remote control system, the surgeon can't feel. So I can't feel what's hard and what's soft. Tumors are hard, blood vessels are soft, bone is hard. I can't feel. So I use my vision to tell me what's good with the robotic system or what I'm supposed to be cutting. But I still lose that manual dexterity, that feel that surgeons have grown to be trained with in open surgery. So in the future, we're going to be seeing things like multi-articulated instruments that could be snake-like, and I'll show you some of the systems that are coming online to do this. We'll have multi-articulating devices. We may even have autonomous delivery of these devices, machines that can you can map their trajectory in space, and they will do part of the operation for the surgeon, much like a drone. Much like the drones that are used to fly now. I heard a really interesting talk yesterday at the festival last night, I don't know if anybody else was there, about airplanes like the Boeing 777 that theoretically has the ability to back out of a gate, take off, fly, land, and get to a gate without the pilot ever touching the consoles. They just have to push buttons. So we're going to see things like that, I think, as concepts of robotics. Robotics is all around us, whether we like it or not. If any of you drive a BMW that has lane assistance so that it doesn't veer off course, that's robotics. Okay? These are not foreign concepts. They exist in the world. We use them now. This is just how we're going to be using them even more hopefully appropriately and more readily in the operating system. Here's a device that's being designed that is sort of like a snake. It's like a scope that can be used to perform natural orifice single incision surgery, potentially of the abdominal cavity. So where are we going in the near and distant future? Healthcare is unfortunately one of the only industries where we don't have a computer model of the product. Nobody tells a young pilot to get in a 777 and take off and let me know how it goes, Charlie. Right? They do hours and hours and hours of training in the console cockpit. They do hours of simulation. They maintain their simulation skills as they get advanced. When new machines come out, when new planes come out, they train on them before they go out and fly them. Unfortunately, healthcare, we don't have such a built system yet. So what I think we're going to see in the near future is that the operating room is going to be an information system with multiple inputs. We're going to have a surgeon that's sitting at a console potentially that's going to get feedback from intraoperative imaging or preoperative imaging. We're going to see simulation and warm-up, preoperative training so they don't make mistakes. So they are more accurate and more precise. Maybe you'll even plan the surgery beforehand and do a mock operation on the computer and then go in and do the real operation on a patient. I think this is where we're going to go and this is what's going to happen in the future. But where do we get the money to support this? Where do we get the funds to do this? That's the question. And this slide is courtesy of the Stanford Robotics Institute. And so one of these ideas is sort of integrated imaging. Here's a company that's taking a CT scan. This is a picture of a lung tumor. Okay, these are big blood vessels that are coming out to feed the lung tumor. This is what the tumor looks like with a scope, with a laparoscope put into the chest. And eventually, we're going to get an overlay. We're going to be able to see the CAT scan overlaid on this image so that it's all put together so the surgeon can know exactly where to cut and know what's coming up before he or she gets there. We may even see these endoscopic workstations. This is another vascular station. I showed you this picture earlier from Hansen Medical. Well, there's a group in France that's trying to do colonoscopies that almost everybody in this room is going to get once we hit a certain age by doing teleendoscopy. You get a surgeon in one place that's operating a machine that can do a colonoscopy in another place. What this allows us to do is not just merely perform the colonoscopy. Anybody can do a colonoscopy, but being able to interpret what they see as they're doing it. Gee, is that really a benign polyp or is that a tumor? Right? That's judgment. That's skill. That's human intellect that can't be readily transferred without time. So wouldn't it be cool if you could show that image to somebody, your colleague, your partner, somewhere else, and you get the brain power of Dr. Jenden telling you, yeah, that's okay, or no, that's not okay. You need to be careful here. So these are some of the interesting areas I think we're going to be seeing in the future. Here's an interesting machine for neurosurgery, for brain surgery, from a company called Symbis in Canada. And they did a first operation on a brain tumor with the surgeon sitting at a console doing a brain operation, knowing that there is tactic feedback. This company figured out how to give that sense of feedback on a brain, doing a brain operation. You can imagine if you poke too hard, you will basically tear an important blood vessel or an important structure in the brain. Once again, prime real estate. Nobody wants to wake up with inopportune brain surgery. So what this company is doing is they've put together this wonderful operating suite with an intraoperative MRI scan and a robot that's image guided so that you can resect just the right amount of brain, not too much, not too little. And you can hopefully do it just right to improve the outcomes of these patients. This is not yet available in the US, but it is being actively investigated. There are other companies from the US and other countries that have single port technology with these flexible snake-like arms. This is one such company called Titan Medical. As a means of disclosure, I don't have any interest in any of these companies. I'm just showing you this because I think it's really cool and what's coming in the future. And yet another company based out of Boston called Med Robotics that has come up with sort of a snake-like device that can actually enter under the breastbone and navigate the beating heart and actually get to points in space on the heart that they can deliver either drugs or they can ablate little areas that cause something called atrial fibrillation, where the heart flutters. There are foci in the heart that give spurious electrical activity, so these could be ablated. And now the company has gotten approval to do this in humans, and they're actually devising a machine that can do actually ear, nose, and throat surgery. And they've done, I believe, the first in human cases in Europe just last week. So this is sort of the surgery of the very near future. And where are we going to go in the very distant future? This is the work that's being done by robotics scientists at places like Carnegie Mellon, at MIT, at Stanford, throughout the country. Here you've got a picture on the top left. If you focus on that area, it's a device called the Micron that basically reduces tremor of a surgeon and is allowing a surgeon to strip the membrane from the retina. This is what happens for patients that have diabetes and they develop retinal membranes that prevent them from seeing very well. These membranes are about 5 microns in thickness. That's 5/millionth of a meter, okay? Really tiny. These membranes tear at about 5 millinewtons of force, okay? They're more delicate than a strand of hair. And this person is able to strip this retina from a cadaver, and you're seeing that. We were gonna have scientists are working on steering needles so they can get into small cavities in the brain or parts of the body that you typically couldn't get to. And you can make these flexible needles that will wiggle in space and get to the right parts of the body. And once it gets there, they're devising machines that can actually deliver drugs with these needles in a very consistent and reproducible fashion. So these are the hammers that are going to be invented. They're being invented. And it's a challenge for us as surgeons, as physicians, to identify the nails that we're going to be using them for. And so, in conclusion, the future is bright. I think that we are in a place with robotics akin to sort of where computing was when I was in college, when a 386 machine was considered top of the line. And you couldn't imagine that there was something you could do with more than 16 megabytes of RAM. And I would guess that every one of us has an iPhone or an iPad or a Apple machine or a PC, and we have so much technology with us now that we can't imagine what life was like before we had it. Yeah. So technology is moving at such a rapid pace that I'm sure we'll find things to do with the technology. Robotics is what people call a disruptive technology because we don't know what we can do with it until we have it. Having said that, we have to remember that these things are expensive, and we are in an era where we have to be cautious of how much we spend. And so the utility of these machines, the cost effectiveness of these new technology needs to be investigated very seriously and with great care so that we don't just spend money for no reason. And so those are my comments, and I'll open it up for discussion. Thank you.
Thank you both. That was awesome. I heard some wows from this area during the presentations. Again, if you have questions, raise your hand and then make your way up to the microphone. Just walk up to the microphone if you have a question. I'm sure you all have wonderful questions. I'll start, and then we can get here. And I guess I want to poke a little bit at the idea that you both mentioned, which is the cost question and knowing whether or not it's worth it. And we were talking earlier, and sometimes people say, oh, you don't know until you have it, so you can't test it. How do you figure out whether or not this billion-dollar set of machines for hospitals is worth it and is going to give you an outcome that is better than something without a machine.
Well, so, talked about shooting for the heart and hitting the prostate. And some of this is serendipity, but unfortunately, the way we innovate right now is we sit in a laboratory. Oftentimes, we come up with these fantastic ideas, and whether it's biorobotics or any number of innovations, and then we figure out where's this going to fit. And what really needs to be considered is flipping this a little bit and understanding what the clinical problem is and deciding how we can get there in the most meaningful way. And so there's actually a science of cost utility where we could say, for example, robotics is used very widely in gynecological surgery and prostate surgery. But what is the utility? What is the benefit to the patient versus the cost, not only of using the robotics, but all that it took to bring this to market? And instead flipping this around and asking ourselves the question, what are the most expensive procedures? And how can we minimize the expense and really make an impact in patient care and quality of life? And so that kind of thinking is something that Uma and myself and others have been talking about, creating think tanks, labs, where we do a lot of measuring before we do any cutting. Right now, there's a lot of cutting, and then we're figuring out how can we find a way to use this and measure it. And so I think that that's where we need to go. I think that it's not very common in medicine. Part of the reason why medicine is in the difficulty it's in. Got a bunch of scientists and technicians who love gadgets. That's not going to fly anymore. Not going to fly. Have a question?
Just to dovetail off on something that you had mentioned earlier about the 777. I fly the 777, and I participated in the NASA Langley program on this, and the conclusion was that it wasn't going to happen anytime soon because of people's acceptance of this. Dr. Jenner, you had discussed something about we can start on certain smaller, less important surgeries and work our way up. Is there any of these that started off on something very serious without patient approval, without the patient's approval? In other words, you can go in there and say, we're going to perform this surgery on you, and not tell him that it's either manual or robotic.
Yeah, no, so we're bound, it's one of the things that's most important in the work we do by ethics and morals, and there's institutional review boards and very, very tight oversight over everything we do, as there should be. And so the idea that you might see in the movies where the surgeon says, for God's sakes, we're going to do a transplant here. This is all we can do. Get me a liver. And they bring it in. It just doesn't happen. The truth is it's a very long evolution that's very tightly watched and followed, and sometimes some would argue maybe too much so, which is why you see a lot of trials overseas, because we simply can't get done the things we need to get done. And there's a lot of technology and a lot of innovation that we just can't get done in a meaningful time period. But no, it's just that's more for the movies than it is. Trust me, we fight that bureaucracy every day.
So what is the next surgery, I guess, that hasn't been done robotically that you look forward to seeing?
Well, I think that, and I'll let Uma answer that as well, I think that the way that we're looking at this now is very different than we looked at it even 5-8 years ago. 5-8 years ago, we said, we've got this robot, what can we use it for? And now we're starting to turn around and say, what are our problems? What are our real sticking points? Head and neck cancer is a great example of where we along the way said, this is ridiculous that it takes me 12 hours to open this thing up and get there for this little tumor. And then we apply that technology there. And so I don't think anybody's really sure where this is going to go next. But I think what you saw that was presented, single port natural orifice surgery, people like minimally invasive surgeries as they should, not because they're enamored with robotics, but because if you can go home the next day with no incisions working through the mouth or through any number of orifices, that's pretty darn good stuff, and we're impacting patient care in a positive way.
I would just dovetail on that and say that there are areas that we probably don't yet understand how to make better. Transplantation is one of them. It's a big operation. There's lots of nuances associated with it, and I know that there are several groups working on using robotics to more minimally invasively harvest a living-related kidney, for example. If you donate a part of your kidney or part of your liver to your loved one, you don't want to get a big incision and be out of work for 2 or 3 weeks. What if we could do that in a minimally invasive fashion? That's one example. The reconstruction that Dr. Jenden showed, once we've taken out bigger and bigger tumors by using these new technologies, we make, pardon the word, a bigger and bigger hole, and we have to fix it. And so doing that in a minimally invasive fashion is another cutting edge area. So I think we'll be seeing a lot more innovation, but as Dr. Jenden pointed out, we're not asking ourselves, what can we do with it? We're, I think, asking ourselves, what should we do with it?
To follow on, can you talk about the approval process? Because many of the surgeries you've indicated aren't approved. So what does that approval process look like? How long does it take to get through? What does the reimbursement cycle look like? And then today, what's the utilization of the equipment in your hospitals? Like, is it well utilized or underutilized? And so we understand what the cost of putting these systems.
Loaded question. First part is easier, and the bottom line is that when we come up with an idea, for example, robotic surgery of the oral cavity, and we'll use that because that's what we're working with today. It could be robotic breast implantation or removal of a tumor in the lung. You go through the institutional review board within your academic medical center. You present to them the data, what's been done, what hasn't been done, what's the safety profile. You know, many times these are placed on trials. The trials themselves have very tight parameters in terms of complications that will cause this to stop, immediately withdraw the trial, and benchmarks that you have to hit to make the trial move forward. It's a complex process that's a relatively good process, and it's all based around one thing, patient safety. And so I think the idea that might be out there, which is probably not appropriate, but has recently crept up again, particularly with this robotic system, is not just getting it through the IRB, but how well trained is the surgeon to use this? And so some of you may have read about the problems that they've had with robotics, using them from everything from thyroidectomy to all sorts of surgeries. The problem here is that these companies have the tendency now to market directly to the patient. So I get patients all the time who come into me and say, I hear you do minimally invasive thyroidectomy and it's through an incision this big. I'd like you to do it with a robot and a laser, please. I say, okay, well, you do it with a robot, the laser. Would you like a magic wand with that? And it's because patients are marketed to, so they don't understand, and it's a real problem that we face because there's always somebody down the street who's willing to prey on that. And that's a real problem. Utility. What's the utility? You know, the reimbursement system is designed right now in a fee-for-service kind of world where the more you do, the more you get paid, which I think most of us or many of us would agree is a real problem. And so if you have a robot and you've paid the 2.5 down and you know you got to pay $200 a year, use that robot. It's in an operating room that's idle, the opportunity cost, get that robot used. And so we're as a result, we're using these robots for cases that they shouldn't be used for. And it's a huge problem. On the other hand, you've got surgeons who say, I want to operate at your hospital, drive revenue, but I need to use the robot. Why? Because my patients demand it. Why? Because they heard about it on a commercial. What's the data behind it? And that's why we're in the process of trying to shift everything to an evidence-based platform. What is the evidence that you have to use the robot or any other instrument for that matter? Or for that matter, what's the evidence that there is to do the surgery? And you've seen all the new data that's coming out on prostate surgery. Now calls into question, should we even be doing that except on a select group of patients? And so we're in a transition period that's critical between what's the evidence and should we be doing this and how do hospitals survive. They got to do these procedures. And so it's a highly inefficient system because of those points that I think you were getting to. Raised. It's not just about using it, it's how are we using it and should it even be used?
driving and I saw a billboard for robot surgery for a hospital, and I was like, I just thought it was very strange.
When we put this talk together, you know, I had great concerns about using the Da Vinci system as my model here because it could portray to you what a fantastic robot this is. And now I'm doing exactly what I just told you shouldn't be done. And that's why it's nice to have Uma's insight on all the different robotic systems. And in fact, the robotic system, the Da Vinci, for what we do, is a very bad system. It's actually not designed for it. It was designed for something completely different. We're just adopting and adapting this technology to what we really need. Down the line, you're going to see robots that are designed to do what we can do. Then you'll really get a wow. Not only because it does it so beautifully and eloquently, but it'll do it at a fraction of the cost.
I have two questions. First, is there any application of robotic surgery in dentistry? And number two, is there anything about joints being fixed, for example, because of arthritis with robotics?
So I'll answer the second question first because it's easier. There's a system called the Mako surgical system. They were recently actually now bought by Stryker. But what they do is use robotics to do joint replacements. So they take a CT scan of a knee, for example, especially it's useful for partial knees, and the robotic system allows the surgeon to appropriately carve using a drill the appropriate resection of the joint and implant a new joint into it. And they've also done similar studies, as I've shown with the Mazer system, where they've shown that novice surgeons can actually have just as good accuracy and just as good long-term joint function as opposed to very, very established and experienced surgeons. So yes, it is being used in orthopedic settings. Dentistry is another cutting-edge area, and currently there are no robotic systems, to my knowledge, that are addressing dental problems. But one would assume that it actually would be a relatively straightforward problem to fix because it's the jaw, it doesn't move, you can take images, you can register across it. So theoretically, you could get a robotic root canal. Is it worth it? I have no idea. You know, it sounds like a long run for a relatively short slide, but I'm sure it's possible. And one other thing that I wanted to mention is one of the most commonly performed robotic surgeries that nobody realizes is robotic is actually the LASIK procedure for eye surgery. You know, a computer maps the shape of the cornea, and basically a robot fires a laser to do incisions along the cornea to make it to get rid of the refractive index. So robotics is everywhere. We probably don't realize where it is.
How do we learn about the major centers where robotics is being successfully performed?
I'll let Eric take this one.
How do you learn? Well, you know, this is not a problem. It's a reality with an unregulated web, where you can get on, and I have people that come to me, and there are some beautiful websites. You'd swear that this was the place to go. The answer is you don't know. You don't know where the place is to go unless you get on PubMed and you can critically read the material. And by the way, if you can do that, please let me know. Because most of the material that's put out there now is done in a flawed way. They're not clinical trials that are randomized and blinded. And we're never going to see those. We're not going to see those because there isn't that drive to do that. And you're not going to take a patient who says, I'm going to randomize you. You will either get, as I will choose randomly, whether you will get robotic surgery or you're going to go through that big face-splitting incision. Are you okay with that? It's not going to happen. And so the information systems and the credibility in those systems right now is poor. And the answer is you're not going to know. Best thing you can do is have a doctor in the family.
We'll be calling you.
Yeah, exactly.
But from a patient advocacy standpoint, I would suggest that all patients be advocates for themselves. You know, go to the literature, look at PubMed. Don't be wowed by a flashy website, as Dr. Jenden points out. And then when you do go to your appointment, ask the hard questions, the difficult questions that you might feel uncomfortable asking. But how many of these procedures have you done, doctor? And what are your outcomes? And have you published on it? And these, if you're in a center, a major academic center, it's incumbent on us to educate the world. So we all publish. The reason we're here is because we write papers on what we do, and we try to be good at what we do, and if we're doing something that's not good, we stop, and we critically evaluate, and we change. So I think those are the best advice.
Thank you.
Good news is that there is on the horizon a platform that will allow patients to get onto the web and actually gain objective data about who does the volume of these procedures, what their complication rate is. You'll be able to determine exactly who in your neighborhood or in the state or in your country does the procedures you need to do and what their outcomes are. So that's coming down the pike, and that's in the process of development right now.
How will we know what that is, what that site is?
You'll hear a lot about it
Okay.
because what it's
Great.
going to end up doing is ranking surgeons.
Perfect.
And there'll probably be such a, what's the right word
Outcry.
without, yeah, there'll be such a
Squealing.
and yelling that you'll know about it.
Thanso you.
Yeah.
So we have about 5 minutes, so hopefully we can get both these questions in the next 5 minutes.
Hi, my name is Christopher Kim, and I'm part of the Bezos Scholars Program. My question is, how do you think the traditional roles of nurses, doctors, and surgeons will change as medical robots become more self-sufficient and intelligent? And to add on to that, would robotics in medicine have the potential to displace people in medical professions, as it would decrease the need for physical manpower, which would in turn reduce the need or reduce medical staff sizes?
It's a dark future.
So I think, I think that that's really far down the road. First of all, as we just heard, there are planes that have very sophisticated technology, but they don't fly themselves because people want people. Patients want human physicians to take care of them and to operate on them. And so I think the concept of fully autonomous systems is really, really far off the horizon. However, as technology changes, the world changes around us, and that's going to happen. The role of nurses is going to change. The way we train physicians is going to change, and I would say it's going to change for the better, because when I was in training, you were either the operating surgeon or your boss was the operating surgeon, and he would supervise you, but it was limited because you're working in a narrow space. Now I can see exactly what they're doing, and we have, at least with the Da Vinci system, a training console. It's sort of like teaching your teenager how to drive, and you have an extra brake, and you can step on it when they're doing something you don't want them to do. So I think training is going to get better from that perspective, and it's a tough question to ask. I think the roles will change. I don't see an immediate reduction in manpower. I don't see surgeons being replaced by autonomous devices. I think the transponder from Star Trek that's going to just fix somebody with a scan is far, far away.
That being said, you saw the picture of the 12, 19 people in the operating room when we do these open procedures, and sometimes we have to do these open procedures. We do, 2 or 3 a week still. Now we've got myself, a nurse, maybe somebody else there just to make me feel less lonely. So there's, we're more efficiently using resources, but I don't think anybody in this room ever is going to want a robot to come up and administer your aspirin or give you a diagnosis. There's still great value in that hand on your hand and telling you you're going to be okay and taking care of you and making a physical diagnosis.
Thank you.
Hi, I'm Samuel, and I'm also a Bezos scholar. And my question is, you've talked about the advantages of the system, of the robot system, and I want to know what are some of the complications or side effects that, through experience, you've realized has posed a threat to even the lives of the patients you actually operate on. Yeah.
Well, I mean, look, the robotic systems that are an extension of what we do, I wish they were magical. People die. People bleed to death. Major structures are cut. Some would argue that if you're going to do it with your own hands, you're going to do it with a robot. Others might say that the robot lacks certain critical things, like haptic feedback, the ability to touch and feel and know the sense. Robotics, unlike human surgery, it's an incredibly complex thing because the way that we look, feel, touch, the sound in the operating room tells an experienced surgeon what he can get away with. When there are tumors sitting on a major vessel, you know, based on the feel and the sense of whether or not you can get that off safely. You lose that in a robot. The robot is not an answer. It's a tool like a laser or a new scalpel or a different type of clamp. It's just a tool. And so one of the things we're constantly pushing on our trainees and residents is that This is just another tool in the bag. Where it fits and when you use it, we're not 100% sure yet. We're getting a better idea, but horrible complications can occur, just like with any open surgery.
And it's I'd extend that to say it's a tool, but because of some of the things that it allows you to do, it's a tool that can take a surgeon to a part of the body that you may not recognize you were going to get there. And so it's a lot like texting and driving. iPhones are great, but when you start texting and driving, it can lead to bad things. So experience, comes from bad judgment. And bad judgment.
We're trained to operate through the outside, right? Now all of a sudden we're talking about operating from the inside out. Everything is reversed.
Right.
If I'm a little dyslexic, it's okay, but if you're not, it can be a real, change in paradigm, and that's part of why surgeons like myself and Uma, who train doing open external to internal surgery, now have to retrain to do internal to external. So it's a complex, and it's probably much more complex than our slides lead you to believe. But really, the purpose of the discussion is to put out there this magical and truly amazing area of innovation that will benefit every single person in this room if it's used properly. That's what it boils down to.
I like that we got the two darkest questions from the two youngest question askers.
The best question.
Yeah, no, that was good. We have 2 minutes. I'm going to ask you a Star Trek question. Many, many years from now, we're talking about sending people to space. We're talking about potentially robotic surgery at a distance, at a very, very large distance. Can you talk a little bit about what that looks like, what the complications might be, and how you figure out when you don't have a surgeon who happens to be a specialist on that mission to Mars, how do you do surgery using that robot from Earth? Is that possible?
It is. I think it is possible. It's on the horizon. Dr. Gendron pointed out that the robotic console as we have now could be 10 feet away or 10,000 miles away. In fact, one of the first teleoperated operations was performed in Strasbourg, France by a surgeon sitting in New York. And it was actually a gallbladder resection with the Da Vinci system. And that happened on 9/10/2001. And so what happened the next day? 9/11. And that put an end to that program. It kiboshed that until now. So we're just now starting to rediscover this idea. And I get asked not infrequently to telementor or proctor surgeons in Malaysia or Brazil or other parts of the world using this console and this platform. So as we get better at communication, telecommunications, I think we will see surgery being performed in long distances in space. It is really Star Trek-y, but it's possible. I think it's not going to happen tomorrow or next year, but we're definitely interested in it. And if nothing else, from the more practical perspective of taking somebody who's in small town USA and getting them the expertise of some of the specialists in the world, which can't always happen.
Well, thank you so much. I want to join in thanking everybody here. Thanks for coming. Thanks, these two gentlemen. I really appreciate it. It was great.